Good morning. I will be talking about neurological prognostication after cardiac arrest and its importance to the intensivist. So, why neurological prognostication in a cardiac arrest patient is important? The most important reason is to prevent futile continuation of care, which may ultimately lead to financial ruining of the relatives and also significant psychological distress. Another reason is to prevent withdrawal of care in a patient who may ultimately regain consciousness. So, the goal of neurological prognostication is to predict poor neurological recovery with complete confidence, that is, a false positive rate of 0. This can be illustrated with a case. This 55-year-old male had chest pain, had cardiac arrest while on way to hospital, was found in VF in the emergency department, was resuscitated after 15 minutes of CPR, found to have ST elevation MI, underwent PCI, and now he is admitted to ICU in a comatose condition. Now the relatives of the patient wants to know what are his chances. So, as we know and shown by this recent survey conducted worldwide among intensivists and neurologists, EEG was the most common modality used for neurological prognostication. This was followed by neuroimaging and then biomarkers. The first thing we do in these patients is the clinical examination. As we know that the pupillary reflexes might be absent for minutes to hours after cardiac arrest. So wait for a while before checking pupillary and corneal reflexes. However, the absence of pupillary reflexes to light at day 3 bilaterally portends a very poor prognosis with a very good specificity. Corneal reflexes have similar interpretation, however, they are more prone to the effect of sedative drugs as compared to pupillary reflexes. The motor response to pain, that is, localizing to pain, generally portends a good prognosis. However, absent motor response or an extensor motor response, that is M1 or M2 response, signifies a very poor prognosis. In this study, which examined motor response and subsequent awakening after cardiac arrest, showed that a poor motor response, that is M1 or M2, portends a poor prognosis. However, it has a false positive rate of about 20%. So, this test should not be used as a single modality for withdrawal of care. The presence of myoclonic status epilepticus, which starts early, that is within 12 to 24 hours after arrest, which is generalized, that is present in all parts of body, like simultaneously in face and limbs, which is prolonged, that is lasting for at least more than 30 minutes, is generally considered a very poor neurological sign. Coming to imaging, which includes CT and MRI. CT in particular and imaging in general are used for neurological prognostication. However, I must say they have a very poor sensitivity and specificity with this regard. CT generally shows signs of severe cerebral edema, like absence of the effacement of sulci and cisterns and loss of gray white matter differentiation. MRI generally shows hyperintensities, which means damage to the areas which are more prone to hypoxia, like the basal ganglia, the watershed areas between the major arterial territories of the brain, and the cortical laminar necrosis. What is important that neuroimaging, including CT and MRI, should be used at least 3 days after cardiac arrest. These changes on imaging might not be apparent before this time period. This MRI shows hyperintense basal ganglia, which is a sign of hypoxic ischemic encephalopathy. This shows watershed infarcts between the major arterial territories. CT in particular and imaging. Coming to EEG, which is the most commonly used modalities worldwide for neurological prognostication. However, the problem is availability of the bedside EEG in our setups. The presence of non-convulsive status epilepticus, which occurs early after cardiac arrest, suggests poor neurological prognosis. Also, the absence of EEG reactivity to any auditory or painful stimuli portends a very poor prognosis. The presence of malignant EEG pattern like generalized suppression. As you can see, the waves are too small in the absence of sedation, or the presence of spontaneous burst suppression, that is the presence of waves and intervals of flat lines in between, which is known as burst suppression, generally portends a poor prognosis. Coming to another modality, which is somatosensory evoked potential, in which the bilateral medial nerves are stimulated and the response is recorded in the cortex, similar to EEG. The absence of bi- bilateral medial nerve stimulation response, that is bilateral absence N20 responses, which is present at least 24 hours after cardiac arrest, portends a very poor prognosis with a very good specificity, and withdrawal of care should be considered. However, the problem is with availability of this test and its poor sensitivity. Coming to biomarkers, when the brain is damaged, it releases various biomarkers. The most important of it is neuron-specific anolis, which can be measured in serum at various time intervals after cardiac arrest. The level of NSC more than 33 microgram per liter 72 hours after ROSC portends a very poor prognosis with a good sensitivity. However, we should consider false positives in patients having hemolysis or patients having cardiac arrest due to cerebral causes like stroke or traumatic brain injury. Again, this point has been illustrated in this study, which showed a very good area under the curve of NSC of 50 at 72 hours after cardiac arrest. Coming to timing of prognostication, should it be done immediately after cardiac arrest or after 2 to 3 days? There are various studies which addresses this issue. The first one was studied the sensitivity and specificity of neurological prognostication done in the emergency department right after cardiac arrest. As this ROC curve showed that as this ROC curve shows the area under the curve of 0.5, that is it really failed to identify patient with poor neurological prognosis at this point of time. It should not be done immediately after cardiac arrest. Another study showed that prognostication done during the time of therapeutic hypothermia, that is within 2 to 3 days, had a very poor sensitivity and specificity to recognize patients with poor neurological prognosis. So the timing should be at least 2 to 3 days after cardiac arrest and after the therapeutic hypothermia has been resolved. So why we need a multimodal approach for neurological prognostic? As we have already seen, all these modalities have poor sensitivities and specificities, and many of these are not available in every institute. We should always go for a multimodal approach. So as soon as the ROSC is achieved, go for a neurological examination, and if the motor response is more than or equal to M5, that is the patient localizes to pain, the prognosis is certainly good and no further testing is needed. However, if this is not the case, then you should wait till at least 72 hours post restoration of circulation and at least 12 hours after stopping of sedation. In between, you should continue brain death testing at frequent intervals. After 72 hours of ROSC, first go for the most robust modalities of identifying a patient with a poor neurological prognosis, which are the bilateral absent pupillary reflexes and bilateral absent SSCP responses, if available. If any of these are positive, very likely the patient has a very poor prognosis and withdrawal of care should be strongly considered. If these two tests are negative or not available, you can go for relatively less robust modalities, which are four and includes presence of status myoclonic epilepticus early in the course of post cardiac arrest, high biomarkers, unreactive or malignant EEG patterns, and CT MRI showing hypoxic ischemic encephalopathy. If any two of these are positive, poor prognosis is likely and you should consider withdrawal of care. If less than two or none of these are positive, prognosis is generally considered uncertain and prolonged observation is advised. But how prolonged should be this observation? Also, the absence of EEG reactivity to any auditory or painful stimuli portends a very poor prognosis. Thank you.